If you allow me, I'll just share a few of my
Of
slides.
course, go ahead. Yeah.
Is my screen visible?
Yes.
So good evening, everyone, and thank you, Dr. Subina. That was indeed a very interesting case. We often read about SLE, but it's very rare to be seeing such a classical case of SLE in our clinics. Now, one thing which is very important for all of us to know that when we have a patient of combined artery and vein occlusion, it can be a combination of any of the following. So it could be a branch retinal artery occlusion with a vein occlusion, or these various combinations which I have highlighted. You can find any one of these. The causes of unilateral combined occlusion primarily are cardiovascular risk factors, which we often see like hypertension, diabetes, hyperlipidemia, obesity, smoking, and metabolic syndrome. But having said that, even in SLE, very often the usual presentation is a unilateral combined occlusion, and it's very rare to find a bilateral occlusion, as was in the case of Dr. Subina. So these are the various causes of bilateral combined occlusions, which I have highlighted in this slide. And of course, SLE was very much the cause in this particular case, which was presented. But the other things which we have to keep in mind is the Behçet's disease, things like Wegener's, giant cell arteritis, even patients with posterior scleritis and ocular trauma also sometimes can present with a bilateral combined occlusion. The clinical features, of course, as was in this case, you can have a hyperemic and an edematous disc, the tortuosity and dilatation of veins. You can have several retinal hemorrhages spread throughout the fundus with cotton wool spots, and also the variable degree of retinal ischemic whitening can be present. I won't go into the details, but of course, as highlighted, you can have a delayed filling of the retinal vessels with a prolonged retinal arteriovenous circulation time, early retinal CNP areas, and in SLE particular, you find extensive CNP areas leading to early neovascularization. And OCT, as highlighted over here, you can have this hyperreflective band secondary to a arteriolar occlusion. Now, coming to SLE in focus, SLE, as we all know, is a chronic autoimmune disorder which affects multiple organ systems like musculoskeletal system, cardiovascular, the skin, the neurological system, the renal system, and all these have to be very much kept in mind. And severe vaso-occlusive retinopathy is a very rare form of retinopathy seen in the patients of SLE, often associated with extensive capillary non-perfusion areas, leading to an early neovascularization and thereby leading to poor visual prognosis. Now, various systemic manifestations of SLE have been described by the American College of Rheumatology, and these are all the signs that we have to look for when we are suspecting SLE. So in this particular patient, though you had the skin lesions and you had several other telltale signs of SLE, but apparently she had never been diagnosed with SLE in the past till she presented with a vaso-occlusive retinopathy in both the eyes and unfortunately with a drastic loss of vision. In young females, what's important to take is the history of miscarriages, which very often happen secondary to the recurrent thromboembolic events. These are the various lab investigations that we have to do in a patient of SLE because they often have hemolytic anemia with neutropenia and lymphopenia. And these are the specific antibodies that we have to look for, like ANA, like the PANCA, the anti-SM antibodies. And what is important are the anti-phospholipid antibodies, both anti-cardiolipin and lupus anticoagulant antibodies, because these are said to be correlating with the occurrence of the vaso-occlusive retinopathy. Surprisingly, in the patient which was presented by Dr. Subina, though the APAs were not elevated, and still the patient had a vaso-occlusive event in the fundus. These are some of the other investigations that we have to do: urine analysis for the impact on the renal, like a renal vasculitis, and also MRI brain, which was rightly done again by Dr. Subina to rule out a CNS vasculitis. When I reviewed the literature, these were several anecdotal reports reporting the cases of SLE who have presented with combined occlusion. The exact pathogenesis of a simultaneous BRAO and CRAO and CRVO in SLE is still unknown, but it is the underlying hypercoagulable state that is considered to be the main underlying cause for a vaso-occlusive event. The acute flare of the disease can be predicted it can be precipitated by any event of acute infection, surgical or obstetric complications, trauma, and neoplastic disease. Now, what is important, another thing is to take a history of cyclosporin, a drug which can cause a drug-induced hypercoagulable state in individuals of SLE and can precipitate an acute event. And of course, lastly, the management. Of course, the hydroxychloroquine is the mainstay for managing SLE patients. And if we have an acute event in SLE, then they can be managed with an intravenous methylprednisolone followed by oral steroids, along with various immunosuppressants. As far as the ocular management is concerned, well, of course, you are going to manage an acute event like CRAVO with paracentesis, with Dimox. But if you have late complications like neovascularization or extensive CNP areas, where the patient is not ready to come back for a regular follow-up, you may opt for an early laser and an anti-VEGF treatment. So thank you so much. These are my points which I wanted to highlight.